For those of you that this is your first NASPA meeting, could you raise your hand? See, once you come to a NASPA meeting, you never want to miss a NASPA meeting. Thank you so much for joining us. We look forward to having you in future years join us. We are a very informal group, and I'm going to quickly get off of this podium and come down, and we're going to have some conversations on some key topics that were suggested to us. We really want for you all to participate, whether you are a NASPA State Pharmacy Association associate member or invited guest. We really welcome your contribution to the discussion, because we firmly believe that together we're stronger. And it's with all of the perspectives that are in this room that really strengthens and helps our core constituency, the State Pharmacy Associations, grow stronger. I believe Florida was the first state that passed competitive language, and I know we rely very heavily on the NACDS regional team to help us out, but we have Florida that has requirements. We have California, which John spoke to earlier. John had to step out, said he's not going to be with us for this discussion. But California certainly has a huge provisions that are pending. But also I'm told that in New York there is a conversation going on, and so does anybody have anything that they would like to share as it relates to any of the activity that's occurring at the state level?
New York for a number of years has been trying to emulate what's going on in California, and we've successfully pushed back. This year they decided to introduce legislation in order to try and get the feds to do something. They're not really interested in New York legislation. They think that eventually there is going to be a national. They don't want to set something up only not to have to follow through on it. So it's gone through one committee. There are many committees. It hasn't gone at all through the Senate. And so we're hoping that that's what we're going to do.
There's been a lot of discussion around the implementation of the Accountable Care Act and how pharmacy is going to fit in. We got a glimpse from Kathleen from the APA. Don't tell Kathleen I called her the APHA Foundation, although it would be a wonderful thing. We have the APHA Foundation with us, but the NACDS Foundation and their investment in some of these new models. I'm going to put my colleague from Iowa on the spot, Anthony, to share a little bit of what y'all are doing in this area, and then really challenge the rest of you to be thinking about what you can share to the group about what your pharmacists are either doing or trying to structure to do as it relates to pharmacists' involvement in new models of care.
A lot of the discussions that Iowa pharmacists have been able to have with, it's now Unity Point, it used to be Iowa Health, a lot of those discussions were from a lot of our community pharmacists saying that the business model for pharmacy is just not working. We need to really transition from a product-based industry, obviously, to a service-based industry. And so we've had a lot of our members been very vocal over the last several years. And we've actually formed a task force that we've termed the New Practice Model Task Force. They finally have been able to reconvene here recently to discuss how we can really work with our Board of Pharmacy to pilot some innovative demonstration projects. And through the work of IPA, we've been able to actually pass some legislation and work with the Board of Pharmacy to approve regulations to allow the Board of Pharmacy, in a sense, to serve as like an IRB, if you will, to approve demonstration research projects that would actually improve patient care. The work that IPA has recently been working on with the efforts of our new practice model is to actually implement, as many of you are familiar with Tech Check Tech programs in institutionalized settings. Our pharmacists have said, we need to make sure not only are our pharmacists practicing to the top of their degree, but even our technicians in the state are practicing to the top of their degree. So let's see if we can pilot a Tech Check Tech program in a community setting, pilot, keyword pilot, within a few of our community pharmacies that are ready and willing to move forward with something. We've had pharmacists in independent settings, in franchise settings, in chain settings come to the table and say, yeah, we are willing to talk about this and see what we can do to make this work. So right now, where we're at is we actually have 3 independent pharmacies, as well as either 3 to 4 right now, within a smaller chain in Iowa that have been working to be part of a phase 1 project We're going to be working with some researchers at Drake University to help us look at the patient safety implications on this, but also the obviously the financial benefits and the financial risk that would be there for pharmacy. Because really we've heard that, as there is a way, if there is a way to make pharmacists more accessible, this may be one aspect to make that work.
What we're seeing, and not just in pharmacy, but in anyone who is connected with healthcare that is going to be assuming risk. So those of us that have been in pharmacy for many years have seen ACOs in one model or another for many years. I think there's a couple of differences. One, I think that assumption of risk is going to be not just at the provider level, right? It's going to be for the pharmacists that are involved. It's going to be for the physicians, and there's going to have to be some way to incent the patient. What we're seeing, what I'm seeing in those customers who want to develop that ACO model, the ones that are doing this in a manner that you think would be successful, and I am a pharmacist, so I probably have, a little bit of a prejudice towards pharmacy as the impact we can have. But we are seeing that move towards pharmacists as a way to help decrease that risk and overall cost. But I would caution pharmacy to make sure that they understand they are going to have to put themselves at the table. So the research that I'm hearing about here is that's fantastic, because that's how we'll have to prove it. But we have a huge opportunity in pharmacy here, and I would have to say that what I'm seeing on the policy side, and from my point of view, is that there is going to be just a very large movement, both in government and private side, towards a non-fee-for-service model of some type. It's evolving, certainly, but I think that's where we're heading. And pharmacy has to be a part of that.
We were very fortunate, I guess about a year and a half or so ago, 2 years ago maybe, new president came into St. Louis College of Pharmacy and really caught the vision of what we were trying to do based on things that he'd already been involved with in New Mexico and other places that he had been. So what we were able to do is craft a position that is essentially 60% funded by our association, working on the network, 40% funded by the college. He wanted to get more involved in community pharmacist practice opportunities, build their residency program, to kind of use us to provide the types of things that they needed within the college. We could use them to provide both funding for the initiative, assistance in helping to set up the network, but more importantly, helping us put the infrastructure behind it, the research, how do we quantify what we're doing if we're having an impact. And so we created a position. We're based in Jefferson City in Missouri, but the staff person is based in St. Louis, has an office at the college, so it's an opportunity to interact with the faculty there, work on programs that both benefit the college and benefit the professional within the state, and has really been able to help us take the network off of the drawing board into practice and look at opportunities where we can implement it. So I guess my message would be there are some unique opportunities working with the colleges.
The Tennessee Pharmacists Association's foundation has been working with Blue Cross Blue Shield of Tennessee. They're our largest health insurer in our state. They provide care for both commercial populations, Medicaid populations, and Medicare populations. We have gone to them and have obtained the grant. We do have a network growing. In fact, next weekend it will double in size as we'll be doing our next network training. And we're credentialing providers to offer services. We have begun with diabetes because they themselves, the insurers of Tennessee, that I meet with the pharmacists that call themselves Managed Care Tennessee. We've been doing that for about 8 years. We asked them several years ago, what's the need, what can pharmacy do for you? And so we took them up on what they told us pharmacists could do for them. Designed the program, went out, pitched the program, obtained a grant. We have about 65 patients enrolled. But I guess the greatest thing, Becky, that I haven't shared with you is that this was initiated by pharmacists working with physicians to identify patients. We're on the radar screen suddenly with the case managers of the Blue Cross insurance company.
In Ohio, we've had a implementation of MTM actually through Outcomes. with one of our managed care organizations, CareSource. They turned it on for 1 million patients, and the last report I had is that they've had over 36,000 interventions with pharmacists, saving over $1 million in hard dollars and over 30 million in avoided hospitalizations. This has spread through several levels of state government, and they're quietly chatting with us in various ways. We now have a grant with the Department of Health that they tried for a federal 5-year grant on some disease management activities, and we put in a couple paragraphs on MTM. They were not funded federally, but they liked the MTM idea well enough that they've taken state money and funded it. We're now trying to figure out what to do with it. So at the end of the day, the beauty of the program that is coming through CareSource is that Outcomes does push their tips as normal. There's one other piece, and that is the pharmacist at the point of the spear makes a decision whether or not to provide medication therapy management for that Medicaid patient. So it may be somebody who doesn't understand how to use their inhaler. It may be a physician that needs to be contacted for whatever reason. But at the end of the day, CareSource is very happy to have the pharmacists be paid for this. Part of it is selfish because they are required to have, I can't remember, 4 or 5 touches with a provider per month, and they count pharmacists as providers. And so that's 36,000 touches they've had since last year that they're quite happy about.
The APHA Foundation had an opportunity at the beginning of this year to hold a consortium and bring together the high users or those who are interested in implementing the appointment-based model together and do a consortium meeting to talk about overview of the appointment-based model, but also tease out the barriers, talk about trials and error of implementation, talk about marketing, and also talk about the business model. And so APHA Foundation will be, and again, off the record, we hope, because you can't control publication, but our white paper should be coming out through e-publication in the Journal of American Pharmacists Association at the end of this month, we hope. We're hopeful it will be out here shortly. In conjunction with the white paper, we are also we had an opportunity to take the tools that so I've been an advocate personally myself with the appointment-based model through the work of NASPA for many years, and so we were able to work with Becky and take the tools through APMS and modify them and also expand them. So there will also be in conjunction with the white paper and implementation guide. So that will be out and available. And it's really, from APHA Foundation, of course I can't speak for Tom Minigan, but it's, APHA is also behind this. Tom was present in the consortium and talking about how this is an enabler to position community pharmacy or provider status so that they're ready to provide these services when we do get it. And so it's, we're behind it and also have an opportunity to continue the work through a research project that will show appointment-based model collaboration with an ACO so that hopefully we can draw attention, again, back to community pharmacy on how we community pharmacy can be in position to really make a difference in collaboration with an ACO through community pharmacy. So.
I've never seen anything that really moves and changes practice, maybe somewhat unwittingly for some, but as much, and has a tremendous impact on adherence. But like we've all said, it really sets that pharmacy up to be providing the chronic care management, the patient care services, and really, I think even without people noticing it, and maybe Bob talked about this earlier, I don't know, I think it was their experience as well. You move from this prescription orientation to a patient orientation, just naturally as you implement this model. And when you do that, then you're set up to do patient care services because your whole practice orientation has changed. So as part of our overall adherence program, which has lots of different facets to it, speaking specific on the medication synchronization, we have the Simplify My Meds program, which has well over 1,000 pharmacists in it now. our annual digest data that comes out in the fall, a little preview that they tell us that 40% of our member pharmacies, of the pharmacy surveyed, tell us that they're doing medication sync. Now, that's not all Simplify My Meds, and it's probably not all full-blown ABM, but at least they tell us that they're doing sync, which is great. On the research front, we have one project that we have about one more month worth of data together. It has about 1,400 patients in it, 13 stores, and like I said, we got one more month of data together there. We're just kicking off another year-long one, which that first study was folks who were already doing some sync, but now they're doing it. They're using some automation and they're gathering some data on it that they hadn't been doing, et cetera. Then we've got another study starting with just a handful of pharmacies that were not doing sync at all, starting from scratch, so there's a little more work with those folks. And we're going to run that one for a year. And we're going to look at some things beyond just the adherence measures, but we're going to talk about some more of the business measures and things that you see come out of at least the Thrifty White, and I don't know if the Bartels and Disco Drug Mart the same, but talking about some of the business impacts, that, what it does to help in the store beyond just the patient care activity as well. We're going to be measuring some of those. And then next month too, we're going to do some consumer research. We're going to do a couple focus groups, get in there and really understand how should we both best be talking to patients about medication synchronization. Does medication synchronization mean anything to them? What's the language that they speak? What we all think we know what the advantages of it are. How do they react to it? Are there disadvantages to it that we don't know about? So that we can then build on that with some consumer-focused messaging, some consumer-focused programming, earned media, those types of things that can help get the word out to the consumers to help drive demand for medication synchronization services from their pharmacies.
What we aim to accomplish is to improve the quality of medication use and management across healthcare settings. And we do that in two ways. One, through our collaborative process with our multi-stakeholder group in developing performance metrics, and also through recognizing examples of exceptional pharmacy quality. So with our medication synchronization program, we feel that we're doing both of those things. Because we see this as a best practice, as a standard that is very much making a huge splash inside of the industry, and for good reason. So in terms of the metric part, it's sort of new news, the newest news, I'd say, that we have around MedSync is that as of last week, our medication adherence B work group made a vote to actually move forward with the development of either a measure or a measure set around medication synchronization specifically. So that's something that is sort of a stay tuned as we roll that out in that work group. But in terms of our medication synchronization initiative, as we're calling it, we're doing something very comparable to Kurt Proctor's work at NCPA, kind of on the chain side, where we're helping chains to adopt medication synchronization, specifically the appointment-based model, through a train-the-trainer program, where we actually go in and show a project coordinator how exactly the nuts and bolts of building a medication synchronization program specifically tailored to that chain's operations would look like, and go through a consulting process with them and getting their pilot or program up and off the ground. So we've been able to roll this out across 2 chains so far, with 3 more who are having signed with us to go through that process in the next coming months.
We did it a little bit different. Everybody knows that medication adherence is a big issue. But we were looking at the fact that how could we help a payer achieve the goal that they need to do our synchronization. And CMS has implemented STAR program, which basically says that if you're a Medicare Part D provider, you have to discern certain levels of adherence for specific diseases. And it's from 76.9 to, I don't know, 74.2. Let's just say it's 80%. Okay? They have to achieve some level in each of these categories of adherence in order to get paid the optimal amount. And so we partnered with a Medicare Advantage plan, University Care Advantage, and we took their patients. And it was pretty small. We only had 135 patients by the time we weeded through those that didn't qualify. But those 135 patients have been in our excellent program. And I basically call those 135 patients every month. We've been doing it for a year now. And we sync up their medications. We use a call center, somewhat similar to 50 White, but we don't automate. Rod's the automation. I'm the automatic call. And so I call them patients every month. And what we found was that at the end of the year, and we looked at our data, that we had increased their adherence well over that 80% level. In fact, in most of the categories, we were at 93 to 95% adherence. These were dual eligible patients. So, they were, sometimes they had language issues. We did this in Tucson, and so I'm getting very good at my Spanish, because I can say no habla español, and does somebody else speak English? But it's an interesting population, and the fact of the matter is, I think that we can, in fact, be very, very valuable. And Bob mentioned it. Those of us who are going to survive in this business have got to bring something to the table. Just producing a product is not going to do that any longer. So this is a way to do that. I mean, we can actually say, look, you have to meet these measures, and we can do that for you through this very simple project. And it has, we just 3 weeks ago picked up another plan that said, okay, you did it for them, what can you do for us?